My job today is to introduce Dr. James G. Lenhart. And I was thinking where to begin to tell you about James, the person. So I have a few notes. If you look up family doctor in the dictionary, you will see his picture. You know that artwork of the doctor sitting next to the child's bed? Totally focused, hand on the chin, watching the child, the patient. Dr. Lenhart is not a guy who sits there with his back to the patient importing data into a computer. He is fully present. When he presents a case, he is not someone that says, the social history is non-contributory, which you often hear from residents. The context, the narrative is always important. So where did this begin? In the spring of 1991, this red-headed, bearded guy from Seattle came in wearing a pink shirt. He was dynamic, he was personable. And after a short while, he became the residency director. He went on to become, within the University of Nevada system, after a short stint in North Carolina, our chair, the vice dean, and then went on to the Nevada system of higher education to become in the chancellor's office. He can tell you more about that. But that's all that academic stuff. But here's the real scoop. Jim is very talented in many areas, from party planning, designing landscape, interior design, and he's a great costume designer. He has great Halloween parties. He's a great handyman, photographer, and also a writer. And his book, Conversations for Paco, will be at our book signing event. He'll have copies of the book for you. But most of all, he is a wonderful husband, father, and friend. As I was thinking about what the heck am I going to say, I just happened to have the TV on and I was watching Gladiator, because I just love that movie and I could watch it over and over. And I thought, Jim is a lot like General Maximus. He's a wonderful leader, not bossy. He's smart, he's courageous. He's respected by the troops at all levels. He's fair, he's honest, and he doesn't ask anyone to do anything that he wouldn't do himself or that is unethical. Residents and faculty alike say that you can count on him. He shows up, he does the work, and I personally would follow him into battle anytime. If you're getting verklempt, Jim, I brought some tissues for you. And he probably would look very dashing in a gladiator tunic, body armor, and sword. But enough about this. Dr. Lenhart and his lovely wife Nancy are here. Welcome, Dr. Lenhart.
Well, I am Jim Lenhart, and Amy, thank you so much for that introduction. My goodness gracious. That was really nice, wasn't it? So I'm Jim Lenhart. I'm a family doc by training. I was lucky enough a few years ago to complete a Master's of Public Health degree as well, and that was really landmark for me, and we'll talk more about that in a little while. I've spent 30 years in healthcare. I've been in private practice, I've been in academia. As Amy indicated, I've been lucky enough to rise up somewhat in the ranks. I spent a lot of time at the University of Nevada, where Amy and I met in 1991. I also spent 8 years with the University of North Carolina, Chapel Hill, and I also spent a couple of years with United Healthcare, and we'll talk more about that in a little while. But currently, I'm the founding program director for a new family medicine residency in Yuma, Arizona, at Yuma Regional Medical Center, affiliated with the University of Arizona. You'll notice in the brochure that my talk is entitled, Has Medicine Lost Its Ethical Compass? And up here it says, Has Healthcare Lost Its Ethical Compass? And I view healthcare as a team sport. Because, I want to qualify this, because I'm a physician, I'll often during the talk about medical education and talk about physicians and so on and so forth. But be sure that anytime I use the word physician, you could substitute equally social worker, nurse, pharmacist, healthcare executive, masters of public health and the like. And by the way, how many physicians are in the audience? Excellent. How many nurses are in the audience? Fabulous. Masters of public health, social workers, Psychiatrists. Medical ethicists. Excellent. Okay. So healthcare is a, what? I didn't say psychologist. I'm sorry, my apologies. Thank you, psychologist. Thank you. It's what?
Humanities, healthcare, humanities.
Excellent. Any others? Okay. Others that I missed? Liberally substitute whatever you choose to with respect to this. All right. I also want to say that I'm going to make some. I'm going to drill down on this ethics thing, and I'm going to make some what some might interpret as derogatory comments about physicians in particular, about healthcare executives. Believe me, healthcare is not all bad. There are thousands of excellent physicians and healthcare workers and the like, but we wouldn't be here today if we didn't need to talk about it. So I apologize in advance if I offend anybody, and so let's the heck get going. I could have titled this talk "Sex, Drugs, and Rock and Roll" because certainly abundant numbers of healthcare providers have lost their way through inappropriate use of controlled substances, alcohol, sexual improprieties, sex with patients, and the like. But we're not really going to spend a lot of time on that today, so that's not the title or the major content of the talk. I could spend an hour or more talking about United Health Foundation's America's Health Rankings, which is published annually and drills down on state health outcomes and compares the bottom states with the top states and the middle states on either side in terms of health outcomes, the determinants of health, what factors go to qualifying them as a top-performing state or a bottom-performing state. More importantly, America's Health Rankings talks about and makes international comparisons. It compares the United States, which spends 15.2% of its GDP on healthcare, yet is 33rd in healthy life expectancy. It's 43rd in infant mortality compared to Sweden, which spends 9% or 9.2% of its GDP on healthcare. It's third in infant mortality and 7th in life expectancy. The United States spends $8,000 or approaching $8,000 per year per person on healthcare, more than twice any other country, yet we have abysmal outcomes. There's something wrong here. We're the most expensive, yet our outcomes compared internationally are in the garbage can. And many, many people believe that we have the greatest health care on the planet. It just isn't so. I could also spend time talking about the recent, and I'm going to do it right now, about the recent Institutes of Medicine report, which drilled down on healthcare waste in our country. They peg it at $765 B as in boy, $billion annually. $765 billion in healthcare waste. $210 billion of that, they said, is from unnecessary tests. $105 billion on inflated prices. And get this, $75 billion on fraud, healthcare fraud. So that's $390 billion. Of the $765 billion of healthcare waste in our country annually, more than half is from inflated prices, unnecessary testing, and fraud. I can tell that most of the people in this room recognize Marcus Welby. I could have called the talk Looking for Marcus Welby. And indeed, I think in many respects we've lost Marcus Welby. Marcus Welby was that wonderful family doctor who in the 60s and the 70s captivated Americans with his caring and with his hand-holding and with his house calls, and he delivered babies. And he did everything right, and everybody wanted Marcus Welby. Everybody wanted Marcus Welby as their family doctor. I could have, and I will talk about healthcare for profit. The question in my mind, and one that we rarely want to talk about, last night in the healthcare or in the healthcare segments of the debate between Romney and and Obama, nobody talked about healthcare for profit. Nobody talked about healthcare as an entrepreneurial endeavor. But we're going to talk about it this morning, and we're going to talk about it a lot. I mentioned that healthcare fraud is a big issue, $75 billion annually. This is in unnecessary tests, it's in kickbacks, it's in illegal prescription writing for controlled substances, it's for billing for tests on patients who no longer live, as well as imaginary psychotherapy sessions. Meet Lana LaChabalet, the mystery physician, the so-called mystery physician, who now is spending 6.5 years behind bars for imaginary psychotherapy sessions. Lana was captured on her way to Canada with an expired passport, a rental car, $55,000 in cash in a backpack, and a bottle of hair dye. And anyway, Lana and her other 5 psychiatrists in the state of California performed and billed for imaginary psychotherapy sessions, a total of $5 million, and so now she's in the cooler. Orange Community MRI in New Jersey gave 13 healthcare providers gave kickbacks to physicians for referring imaging studies to them, kickbacks. They are now being investigated and brought to justice. Doctors Madai and McLean in Maryland, cardiologists, performed unnecessary cardiac catheterizations and performed unnecessary cardiac coronary artery stenting. McLean, to the extent that he is now serving an 8.5-year prison sentence. My friend, no, not my friend, Deepak Desai, a gastroenterologist in Las Vegas, who so controlled the gastroenterology community that he had 23 gastroenterologists in his stable, all of which had on one hip a colonoscope and on the other hip an upper endoscope. And they scoped and they scoped and they scoped. They scoped when it was necessary. They scoped when it wasn't necessary. And in the trial, in the initial investigation, Desai, this person, was doing 60 colonoscopes a day. Now, you'd have to do that you'd have to do one of those about every 7 minutes. And it just is not possible. So something was not quite right. And in fact, in the hearings, many gastroenterologists declared that was just physically impossible, no way to turn things around. But they were all performing multiple, and many endoscopies. Now, so he pushed up the revenue, but Desai did something else. He pushed down the expenses. He cut gauze sponges in half. He reused needles. He used single-dose propofol vials as multiple-dose vials. So that when the Clark County Health Department traced 6 cases of hepatitis C back to the Southern Endoscopy Clinic, the Endoscopy Clinic of Southern Nevada, Desai was in trouble. He has now not only had civil charges brought against him, but criminal charges because one of the patients with hepatitis C has died. It's not that long ago that it was entirely unprofessional to advertise our services. We just didn't do it. The care that we provided, the hands that we held, the quality of what we gave people was advertising enough to build a robust practice. Now it's common to see primetime advertising, billboards all over town, the best emergency room, the best hospital, the best this, the best docs, the best kidney specialists, and the like. We didn't need Madison Avenue gimmicks to promote our practices. We did it because we were good at what we did. We did it because we were the Marcus Welbys of the world. She was pretty, she was vivacious, she was articulate, and she was even just a little bit sexy. I'm talking about the pharmacy detail person who came to my office. She made office calls. And she gave me samples of medications that then I could pass out to my patients and provide them a starting dose, a launching pad for me to then prescribe the brand name medication at extraordinary costs. But the Stark laws came in and said, oh, wait, She also not only gave me samples, but sometimes she provided me with CMEs or a dinner of filet mignon and all the Opus One that I could drink. Because regulators saw this as a conflict of interest, Stark laws came into being, and they made it very difficult for pharma to continue this practice of influencing me, of conflicting me with best practices. So we lost the articulate, vivacious, and sometimes we lost her to, well, pharma to not be outdone, replaced her with primetime advertising. It's projected that primetime advertising costs, or pharma spends $30 billion annually on primetime ads. A primetime ad costs $110,000 per 30 seconds. The cost of primetime advertising is greater than the amount pharma spends on research and development. Now, they target two audiences. They target the patient who comes in and says, "Hey, doc, I'm having trouble with my insomnia. And I saw that ad on television. You know, the little butterfly? Can you give me the medication, the one with the little butterfly?" So they very much influence patients, but they also target and they influence physicians. And that's the reason why at the end of all these advertisements, it gives the side effects and the risks and all those factors. It's that pretty vivacious girl who's now on prime time telling us that she has the best drug going, that my drug is better than Viagra, and I ask you, what's in your bathtub? Meet Messrs. Andrew Whitty, Ian Reed, and Miles White. Now, these three gentlemen have in common that they are the CEOs of GlaxoSmithKline, Pfizer, and Abbott Laboratories. They also have in common that in the last 3 years, each of their companies has had to pay fines in the billions of dollars for non-FDA approved promotions of their products. In the instance of GlaxoSmithKline, the fine was $3 billion. For Pfizer, 2.9 for GlaxoSmithKline, 3.2 for Pfizer, and 1.5 for Abbott Laboratories. Pfizer promoted their pain prescription, or their pain drug, Bextra, for non-FDA approved purposes. Wellbutrin and Paxil were promoted by GlaxoSmithKline. And for Abbott Laboratories, it was about Depakote. But here's what made it even more egregious. They gave kickbacks to providers for promoting and prescribing these non-FDA off-label uses. Now, if that were me, if I did that, I'd lose my job, right? We'd all lose our jobs if we did something so bad for a company. Well, Andrew Whitty got $10.7 million in total compensation last year. Not to be outdone, Ian Reed, $25 million in total compensation last year. And at Abbott Laboratories, the top executives reeled in $48 million in total compensation. Miles White got 25 of that 48. Meet Richard Bracken, the CEO of Hospital Corporation of America. Hospital Corporation of America is the 90th largest company, according to Forbes, 90th largest company in the United States. $30 billion in revenue in 2011. Now, Richard Bracken only got half of what some of the gentlemen that I just talked about. Richard Bracken made $5.7 million last year. Now, why do I bring Richard Bracken into the equation, who's the guy at the podium standing next to Vice President Biden and Kathleen Sebelius? I bring Richard Bracken into the equation because Richard's company is now being investigated for inappropriate and unnecessary cardiac testing and cardiac stent placement. Zanos Grekos, Bonita Springs, Florida. Cardiologist and entrepreneur. Zanos Grekos owns and developed a company called Regenocite. Regenocite has Regenocide is a company that takes a sample of tissue, in particular blood, sends it across town to its little laboratory, reprocesses it at some kind of stem cell, and then re-injects it into patients with cardiac and pulmonary conditions. So Xanos Grecos has created this company that does this non-FDA, non-scientifically proved procedure in patients who are at their wits' end in terms of a therapy. They've been told by their other doctors that there's no cure for their heart problem or their lung problem. So enter Xanos Grecos with his company Regenocide. Now, things were going well with Xanos until a couple of years ago when in a woman with breast cancer, he re-injected her stem cells after he'd processed them in her laboratory, and she died. So the Florida Medical Board got wind of this, and they slapped him with a restriction. They said, you know, you can continue to practice cardiology, you can continue to be a heart doctor, but you are restricted from injecting stem cells in patients. You can no longer do this. But Xanos wasn't going to let go of his company Regenocide, and he wasn't going to be outdone by the Florida Medical Board, so he moved it an hour away to the Dominica, where there aren't regulations and where he could practice this stem cell treatment freely. He has a friend, Konstantin Yankopoulos. Konstantin is an OBGYN, but Konstantin advertises on his website that he's a family doctor. He's a board-certified OBGYN. He makes himself out to be a family doctor who's an expert in anti-aging, hormone therapy, rejuvenation, and the like. Now, for reasons that I don't understand and the legal documents don't point out, Grecos had a patient who he felt needed to get the stem cells sooner rather than later before he flew him down to the Dominica. So we called his buddy Konstantin, and the conversation went something like this, at least I imagine. Hey, Konstantin, it's Xanos. Hey, yeah, how you doing? I'm doing great. Yeah, thanks. How's the missus? Hey, okay. Hey, listen. Hey, Konstantin, I got a little problem here. I got a patient. He's got pulmonary hypertension, and he needs some of my stem cells. And you know the Florida Medical Board, you know those dirty SOBs. Hey, they made it so that I can't inject my stem cells. Now, I ought to be able to do that, and you know that this is a great therapy. We've talked about it over wine, and we've talked about it over dinner and golf. And so here, I got an idea, Konstantin. How about I get the blood sample, you come on over at 2 o'clock after they've been processed, and you inject them for me. There's no restriction for you. I'm thinking, hey, this is kind of a neat idea. We could buddy up on this. And Konstantin, don't worry about a thing. I'll make you whole on this one. So the patient comes in, 2 o'clock in the afternoon. The blood has been taken out of an abdominal blood vessel for one reason or another, processed in Grecos' Regenocide laboratory, and the patient is prepped to have Konstantin Yankopoulos, who does not have that emergency restriction, inject the stem cells. The patient's complaining of a little abdominal pain when he comes in, but hey, he's here to get his stem cells re-injected or injected. So they prep him up. Yankopoulos injects the stem cells. The patient's now complaining of a little more in abdominal pain, but after all, they probably had a golf game or to go get a drink together. They send him home, and he dies. The patient dies. He exsanguinates into his abdominal cavity. Well, this time the Florida Medical Board said, Grecos, your license is suspended. Now, I would think the Florida Medical Board would also say in this scenario, which is painted clearly in the complaint, I mean, I've read it, I've read the whole deal, that Yankopoulos was an accomplice in this. But the Florida Medical Board, the only restriction on Yankopoulos is that he can't inject stem cells. I don't get it. Andrew Wakefield, the British investigator and researcher and scientist, in 1998 published his research which showed that the MMR vaccine was the reason for the dramatic increase in autism. 10 years later, it was uncovered It was uncovered that Wakefield's research was very conflicted. The data that he presented was manipulated, and indeed there was no link between MMR vaccine and autism. Now, why would an academic, a researcher, why would they want to do that? Well, there's a simple reason. Andrew Wakefield held a patent on a new measles vaccine, and he held diagnostic testing patents for other related entities, thought to be worth an annual sales of around $43 million. Anybody know this guy? Your buddy and mine, Dr. Oz. Now, Dr. Oz he's got an hour show every day, you know, he's got all this fancy stuff. I've even seen poop on Dr. Oz's program. Why am I talking about Dr. Oz today? Why did he make the notorious list? In July of this year, Oz said that raspberry ketones were a miracle fat burner, that all you needed to do was couple raspberry ketones with diet and exercise, and the pounds would melt away. He said that research showed that raspberry ketones were indeed a miracle fat burner, and all you needed to do is take one capsule twice a day, exercise and watch your diet, and you'd be good to go. So I'm fascinated. I mean, I want to be able to prescribe raspberry ketones and recommend them to my patients. Why wouldn't I? So I go into PubMed and I do a National Library of Medicine search, and I'm going around and I think there must be something here. Finally, I found it. The research was in 2005. It was on mice. One published research, 2005, on mice. I think that's snake oil. Many of you may recognize this gentleman. This is Arthur Caplan. Now, who's to blame all the people that went before me? Who's to blame them when Arthur Caplan, an esteemed bioethicist at the University of Pennsylvania, recently responded to a survey which showed that 20% of physicians failed to 20% of physicians failed to disclose that an error had been made, a mistake had been made. 15% of physicians failed to disclose that, or they painted a rosier picture with respect to a diagnosis or a prognosis, and 10% of physicians failed to disclose that they had a conflict of interest. Now, Caplan, in his defense, did say that it was never appropriate to not tell a patient when a mistake had been made. On the other hand, he said with respect to painting a rosier picture, sometimes it might be in the best interest of the patient. He said, especially with respect to conflict of interest, most patients don't care anyway, so quote unquote, you can get around that one pretty easily. Now, I'm not here to challenge Arthur Caplan, but I would say to all of you today, if we take any message home as medical educators, as healthcare educators, as psychologists and physicians and nurses and social workers and the like, we must hold ourselves to the very highest standard when it comes to medical ethics. And I don't think there's ever a reason why any learner would want to think that maybe it's okay to hedge a little. Because if we tell them it's okay to hedge a little, it becomes okay to hedge a little. DaVita is the largest dialysis second largest provider of dialysis service in the United States. They're second only to Fresenius. DaVita recently purchased Healthcare Partners. DaVita has $7 billion in sales annually. In purchasing Healthcare Partners, they purchased a large group, the largest group in the country of physician services. They're primarily in the Southwest, but they're also in Florida. They paid $4.5 billion for Healthcare Partners. Well, what's so bad about that? In the best world, primary care creates the foundation. In the best healthcare system, primary care forms the foundation. Up to that, we refer to specialists, the subspecialists, the others. Primary care is their specialist. We refer up to the subspecialists. Subspecialists then get the high tech, do the high tech, and perform those tests. That's a well-designed healthcare system. This model puts technology at the foundation, the subspecialist someplace in between, and the primary care doc someplace in the ozone. Now, I talked a little bit about Stark laws. Stark laws, besides restricting pharma, Stark laws also make it inappropriate for physicians to own companies and refer to those companies. In other words, I can't own an MRI company and refer my patients to that company. That is fraud. There are no Stark laws that say a technology company can't own physician practices. Now, if that's not a conflict, and a conflict that I think needs to be investigated, I don't know what is. And I can promise you this, as it pertains to kidney disease, those primary care docs will be the best educated on chronic kidney disease and when to refer to dialysis that you can ever imagine. He's not a doctor, he's not a psychologist, he's not a healthcare worker. This is Warren Buffett, the richest man on earth. If you don't think the DaVita deal is a good one, he owns 6% of the stock. Now, this is not just about cardiologists and gastroenterologists and high-flying CEOs. This is also about me. As a primary care doc in a fee-for-service system, every day I make the decision 25, 30 times a day to code a 99213, which pays less than a 99214. And the only magic is to make certain that I've documented the encounter sufficiently to value it as a 99214, a 99215, or whatever that case may be. So we spend our day trying to justify an upcode. And if we don't, it's Medicare fraud. But with electronic health records, it's been pretty neat. It's pretty easy because we can cut and paste from a previous visit into the current visit. And in fact, Medicare calls that cloning. And in fact, they're beginning to investigate it. And in fact, it is a conflict of interest. So I ask you, have I convinced you, or have I made a case for us being a healthcare system that's profit-centric? Is it physician-centered? Or is it patient-centered? One last ain't it awful, and then we'll go on to recalibrating the compass. This is United Healthcare. I worked for them. $102 billion annual revenues. $102 billion. 22nd largest corporation in the country. Multinational corporation, for that matter. They had $8.5 billion in revenue in 2011. This is Steve Hemsley, the CEO. Steve's up in that group of 10 million a year. He's worked for the company a long time. He's been the CEO for about 3 years. Now, that's not the rest of his story, because he owns 2.7 million shares of United Healthcare stock. United Healthcare stock recently sold for $52 a share. Do the math. That's a largesse of $142 million. Not bad. Not as good as some baseball and basketball players, but not bad. This is one of the good guys. And if you don't recognize him, that's me. I started Conversations for Paco in 2011, and I started it because I had encountered a true story, a true case, a real story that really plucked my heartstrings. And it was about at the end of the day, about physician indifference and healthcare for profit. And I instilled it with some of the characters that I've met throughout the years. And Amy, maybe you're even in the book. But I did this as a novel because I wanted people to read it, and I thought if I did this talk in a nonfiction sort of form, everybody might read the introduction, or not even that, but throw the book down and say, the heck with it. So I began writing it in 2007, and then in 2009, I took a job with United Healthcare. I was lucky; it published in 2011, and around the time of publication, I went to the president of the Nevada market, the big boss in Nevada, and I told him of the book, and I told him it was critical of healthcare for profit, and I told him that he might not like what's in it, but I wanted him to know about it. I didn't want him to be blindsided or taken aback when he learned about Conversations for Paco. That was September 2011. I autographed the copy, and he said, Jim, you don't need to worry. We respect people's right to freedom of speech and expression. Congratulations on the book. And we parted company, and in January of 2012, the Las Vegas Business Press interviewed me about my book, Conversations for Paco, and in it I declared that it was about healthcare for profit. And I said, we're not patient-centered enough. It's too much about profit now. Well, the article went to press and published January the 9th, and a week later, my supervisor, not the guy that I gave the book to, but my supervisor called me into his office and said, Jim, we're not happy, and we're slapping you with a corrective action. You didn't vet the book before the article before it got published. You didn't get it approved by United Healthcare before it was published, and I agree that that was probably a mistake and pretty dumb for somebody as old as me. But we also don't like the content, and we're not very happy about what you've declared around healthcare for profit. A month later, I was financially disciplined for the same reasons. A month later, Human Resource called me into their office and told me that I had to declare Conversations for Paco, any sequels, any nonfiction writing, my little television show, and anything else I did that was of intellectual property, a conflict of interest with United Healthcare. In other words, they'd effectively censored my work and restricted my freedom of speech and creativity. I submitted my resignation May the 11th of 2012, happily, and became the founding program director for Yuma Regional Medical Center's new family medicine residency. So let's spend a little time recalibrating our compass and go there. Yesteryear, 1850. What physicians could do in 1850 was indeed important. They made house calls, they held trembling hands, they boiled water, they wiped foreheads, and they addressed the social determinants of health. I didn't know about the social determinants of health. Nobody ever taught me that. For that matter, nobody ever really taught me very much about medical ethics in all of my education. But I didn't know about the social determinants of health until I began my Masters of Public Health program. Let's look at this slide just a little bit, and let's talk about the social determinants of health and why they're important. This is the patient. The patient comes with a complex of DNA and the like. He's got a family that supports him. Providing he lives a healthy life or not, his outcomes are impacted. We all know in this room about the importance of social and community networks. And surrounding that are the social determinants of health. Housing, healthcare services. This is where I live. I don't live here. I go there. I hope I'm patient-centered, physician-centered. Ooh. Healthcare services, water and sanitation. That's what they did in 1850. Unemployment, I don't know what they did with that. But they also knew about work environments and the impact of ugly working conditions. So they addressed those. They addressed education and they addressed food. Now, if you don't, and out here someplace lives policy. That's where our governments and regulatory bodies live. That's where we create the culture and the environment to better health. If you don't think the social determinants of health are important, let's look at these graphs. Now, I don't expect you to see a doggone thing here, but I'll explain it to you. This is 1850, this is 1850, 1850, 1850, and I apologize that you can't read these, but I did my best. I always do my best. Okay, so tuberculosis, whooping cough, scarlet fever, and measles. The mortality from these diseases was extraordinary. This is 1940, 50, 40, 50, 40, 50, 40, 50. By addressing the social determinants of health, take measles. Look at the dramatic impact of addressing sewer, water, agriculture, food, and the like. This is what reduced the mortality from measles, not vaccines. After the development of the vaccines, the mortality doesn't change very much. And the same is true for the rest of these diseases. 1940s, 50s, 1940s, 50s, 1940s, 50s. Look what happened to scarlet fever. They didn't have penicillin then. They didn't have penicillin until right here. But by addressing social determinants of health, had a dramatic impact on health outcomes. This slide reminds us that no treatment, no antibiotic, no vaccine, no high-powered medical education can adequately address the impact of poverty and the other conditions of society which lead to poor health outcomes. So one of the things that I ask all of you today is to consider engaging in the social determinants of health and in our communities to arrest those factors. By going to our communities and by creating a stronger network, by being volunteers for the Habitat for Humanity or the food bank or other kinds of community engagements, we can change and we should change health outcomes. We must be role models. The Accreditation Council for Graduate Medical Education recently published in June of this year an article of research from UCLA and the medical residents there, which showed that the best way to attain the 6 competencies prescribed by the ACGME was through role modeling, that they most efficiently and effectively acquired the competencies by role models of their peers and their mentors. This is Hippocrates. He lived 2,500 years ago. He is the father of medicine, of modern medicine. Wow. And the first author of, at least thought to be the first author of medical ethics. Beneficence, do what's right for the patient. Malfeasance, first do no harm. Truth-telling, autonomy, confidentiality. And most importantly, at least I think, the concept of distributive justice, that we must indeed ensure that in our policies and our plans and in our activities that we do, that everybody has access to quality health care. We need to be advocates for it. We need also to judge our learners and our learners-to-be by standards other than objective tests. Now, I don't say that they're not important and they're not beneficial and they create some sort of a bar, but it's clear that we're going to miss people with heart if we only look at GPAs and test scores to determine whether or not they're an eligible applicant. So I think that interviewing is critical. And if we're going to recalibrate our compass, we need to do a better job of the interview. We need, the objective test is going to tell you whether they're smart enough, but if they're not a critical thinker, are they a systematic thinker? And I think interviews can bring that out. We need to talk about life. We need to talk about life experiences and how those life experiences shaped character. And in talking about life experience, see if there's a little bit of heart in there, and maybe if their heart is as big as their head. We need to talk about educational experiences. What professor was the most influential? And what can you do to be like that individual? And when you had an educational stress, how did you deal with it? And when you have any kind of a life stress, how did you deal with it? And what is this individual's character made of? We need to talk about behaviors. Does the applicant raise pit bulls or rescue golden retrievers? Does the applicant volunteer for wilderness duties? Or is his hobby the New York Stock Exchange? Does he shoot Bambi or does he ride a mountain bike? And who's his best friend? Who's his or her best friend? And what characteristics about the best friend do you admire? And what do you do to try to be more like that individual? Medical school costs are extraordinary. And all educational costs are now extraordinary. And in fact, one of the things that drives me just a little bit nuts is education has become an entrepreneurial sport. Especially the online courses that are very, very expensive and not necessarily achievable in terms of their outcomes. But medical school debt average debt is $145,000. A graduate of medical school comes out with that, and up to $350,000 or more. Now that's not good for 2 reasons. And as we recalibrate our compass, we need to address the cost of healthcare education. It's not good for two reasons, because on one hand, it influences what we will choose as a medical specialty. Because I know if I'm only going to make $160,000 as a family doc, why would I want to do that and never, ever be able to pay back my student loans? But if I'm an anesthesiologist, I'll get there and also get my little red sports car. But there's another reason I think that we need to address the cost of medical education, and I call that building entitlement. Medical students are just a little bit entitled anyway, right? But if you go through medical school and you accumulate a bunch of debt, and then after you go through medical school, you go through residency and you earn a little bit of money so that you're okay, and now you're 35 years old, tired and burned out, and in debt, aren't you just a little bit entitled? I think so. I mean, I certainly felt that. I don't think that's wrong. If we're tired and we've worked hard and we built this thing and we want to use it, I don't have a problem with that. And I like it that I can make a good income. I don't have a problem with that. I have a problem with the extraordinary amount of income that some physicians make and how they build it and manipulate it and commit fraud around it. But that said, I think it's important for us to legislate or advocate for federal programs which mitigate the cost of healthcare education. I think that's appropriate. And furthermore, if United Healthcare can make $8.5 billion a year, if Glaxo and Pfizer can make billions of dollars, and if Hospital Corporation of America can make billions of dollars, shouldn't they have some skin in the game? Shouldn't they have some skin in the game to play in the sandbox and mitigate the cost of healthcare education? I think they should, because they're going to use all of us to make their wealth and make their billions in the future. We need to meet with our learners often and frequently and have support groups and balance groups. We need to talk with them about healthcare ethics. We need to talk with them about conflict of interest. We need to talk with them about healthcare fraud. I've never had anybody ever pimp me because I couldn't articulate medical ethics. I've certainly been pimped plenty of times for not knowing the renin-angiotensin system or what the best evidence shows around hypertension and JNC7 and the like, but never once pimped about healthcare or medical ethics. I think we need to do that. I'm not talking about pimping. We need to articulate it, we need to role model it, and that's part of recalibrating our compass. I think we need to examine our state medical boards and how they behave and what happens when somebody like Grecos and Yankopoulos perform the kind of fraudulent, non-approved, non-researched, totally fraudulent sort of ethics. Why should a medical board say, well, geez, I really hate to strip him of his license because he won't be able to practice anymore and he won't be able to have an income? As a companion to the Institute of Medicine document on healthcare waste, they published 10 recommendations to improve healthcare, to improve the quality of healthcare at a lower cost. They did talk about patient-centered care. They did talk about the value of centering on our community and making care community-centric and bringing the community into the equation. I was amazed, and I'm a bit disappointed, that nowhere in those recommendations did they address healthcare for profit, or did they address healthcare as an entrepreneurial activity. It makes me wonder if we're afraid to have the discussion that I'm having this morning. This is a very political time. We've got one candidate who says on day one he'll repeal the Affordable Care Act. We've got another candidate who says that it's the greatest healthcare legislation of the past 100 years. We've got the Tea Partiers arguing with the Republicans, and the Republicans arguing with the Tea Partiers, and the Democrats arguing with both of them. I submit that healthcare is not a political hot potato. Healthcare is not a commodity to be bartered or sold to the lowest bidder. Health is a human right. Health is a human necessity. And I think it's just so important that we get the politics out of the equation and get to the policies that create the kind of healthcare environment that's best for everyone. So I ask again, are we profit-centric? Are we physician-centered? or are we patient-centered? Will lightning continue to strike? Or if we recalibrate our compass, if we're role models, if we embrace healthcare ethics and teach it, if we deliver on patient-centered care, if we value community centricity, if we address the cost of healthcare education, if we learn about our applicants when we're interviewing them, if we teach the social determinants of health, if we encourage volunteerism and we challenge healthcare for profit, we'll develop people like Ed Paul. Ed Paul, who's devoted his life to healthcare education, and more importantly, devoted much of his career to leveraging the legal system to address healthcare disparities and healthcare inequities. We'll develop people like Mark Chris, a thoracic oncologist at Columbia University, who in his spare time travels to Haiti to relieve earthquake victims, who travels to New Orleans to engage in the activities around Katrina. And when in his spare time beyond that, is an advocate and an activist in healthcare, in Habitat for Humanity. We'll develop women like Catherine Wisner, who's devoted her life to the treatment of postpartum depression, and physicians and doctors Ray and Lemley, who rescued Gabriella Giffords from the clutches of an attempted assassination. And we'll develop individuals like Butler and Hoffman and Steinman, who recently won the Nobel Prize in Medicine for their groundbreaking work in immunotherapy. There can be and there will be a brighter day if we recalibrate our compass. It's been my pleasure to be with you this morning. I am honored deeply. Thank you for listening and not yawning too much. It's really very cool, and if we got some time, I'd love to answer some questions.
European systems have limited the amount of profit to something like 18% or whatever that that any company, insurance company or healthcare plan, can actually accrue. So that one of the ways that they have kept some of their healthcare costs down is by not allowing people to become so entrepreneurial about this. And I haven't heard anything. I mean, people are always talking about decreasing healthcare costs, but I haven't heard anything about limiting the amount of profit or demanding, for example, that only 15% of their costs be used for central administration. I mean, there are all sorts of little ways in which they've governed other institutions, like 501(c)(3)s, where they have to spend a certain amount of money on actual care or actually outreach or whatever it is that that particular institution is doing, and they cannot spend beyond a certain percentage on their own administrative costs. So I guess what I'm getting to is, why are we not looking toward that kind of a system as a way of helping with costs? One last thing is, I remember the head of Exxon, as they were making billions and billions and billions of dollars at the time of the oil crisis of the past couple of years, saying, I am beholden only to the people who hold shares in my company, and I have no civic duty beyond giving them a profit. Two comments in response to that. One of the things that the Affordable Care Act, I'm not here to talk about the Affordable Care Act, but one of the things that it did do is require insurance companies to spend, depending on the size of the health plan and so forth, did limit the amount of money that could be spent on executive pay and other administrative costs, so that just generally speaking, 85% of the premium dollar needs to go to patient care and patient services. So there was sort of an artificial limitation going on there. So that part's good. The other thing that I want to clarify is, when I'm speaking of healthcare for profit, I'm talking about companies that are listed on a stock exchange for which
individuals can invest in that company and get return on their investment. I'm not talking about a regional medical center that needs to make a contribution to margin to stay afloat, but reinvest that contribution to margin back into the medical center. My dilemma with healthcare for profit is they take it and they've got it. And that cost is the cost of patient care. And the same would be true for individuals who invest and then reap the rewards of that investment. Yes. And I'm happy to be challenged about this. Listen, if there's somebody or if there are people in this room who think I'm crazy about this healthcare for profit thing, I'm love to hear it.
Well, I don't necessarily say that I totally disagree with you, but one thing that I'd point out with OJ is that if you look at our foundational documents in this country, one key statement is the pursuit of happiness, which includes financial gain and is part of the reason people came to this country. So if you want to limit that kind of thing, you're talking about something that's a foundational change in our philosophy. And I'm sorry, I don't think that's going to happen.
I don't either.
Whether it should or not, it's not going to happen. And I don't necessarily disagree with it because, if you go out and you put the effort into it, that's the one thing that has spurred us on. The other thing is now, where do you put your ethical limits? And that gets back to it. Where in your heart do you feel you have an obligation to come back? And obviously, when your company is going out and making lots of money and you have investors in that, part of the reason you're doing things is you got to keep the investors happy. If you don't,
that's exactly
you're
the
really
point.
in trouble.
That's exactly the point. Listen, if this is, let me make this statement again just to challenge you. Healthcare is not a commodity that should be bartered or sold. I just don't think it is because it's not in the best interest of you or you or you or anybody else out there.
I don't disagree with that, okay? I just look at the reality of what it is, and the fact is, now you look at your debt and what goes on, and, if you've got a family and what goes on, I don't care what happens out in the community in the end, because in the end, the first place I'm going to look is in my family. And if my family needs that, they're going to get that. But this is a side thing. There are a couple things with recent experience that I've had. You talk about ethics. I had the experience very recently of having to moderate a section on ethics for the residents getting ready for their in-training exam. None of the residents have ever had any formal training anywhere in their experience on ethics.
Exactly.
I had to sit, and what I did is I outlined ethics. I have a 7-page outline that says, this is what the basic concepts are. Here are the types of things and thinking you do, and here are these terms, and this is what they mean, okay? I looked at the test, and I don't think I could have passed it because how I think ethically is not how they think ethically. So this is a bigger challenge than what you think. The other thing is about taking students in. If you look at communication skills, you can come in and have students in medical school communicate better when they're in their first and second years. So there's a big, huge change that has to be made.
Oh, this is a huge problem, and I know that we're way out of time, and I really appreciate your listening to me and processing what I've had to say, and I hope at least some of the message strikes home and recalibrates your compasses.
We still have a few more minutes.
We do have a few more minutes?
Yeah. Mark,
Okay,
Mark,
Joan says we have a few more minutes.
I had seen
And
you
I
had your hand up
agree
earlier.
with,
Did
I
you?
mean, it's a huge issue.
Oh, he did.
But much of the issue is conflict.
Am I on? Yeah. To go back in some ways to this idea, I have a sympathy with the entrepreneurial idea. I mean, we want people to go start regional medical centers, and they have to have some incentive to do that. But it also doesn't need to be financial. And I think one of the things we can't legislate, but we can teach, is that happiness can come from something other than money. I mean, what is the actual marginal value of $7 million to $8 million for that CEO versus how that $1 million could be spent in terms of happiness for other people? And if we could get this, I mean, and that's not about money. It's about, I make more money than you do. That's an identity goal. That's not a financial goal. It's not a content goal. So if we can get people to understand that, you know, all right, we'll pat them on the head because that's really what this is about, and that doctors can learn that there are other things that can reward them besides money. I mean, if their practice is more satisfying, you know, then they don't need to make the money and have the sports car to make up for the fact that they're stultifying work because they have to see patients every 12 minutes.
I guess I'll introduce a somewhat maybe controversial in that I work at a Catholic healthcare center, and what I would say is that the ethical imperative is much more important for us. And maybe it's unique in the hospital I work at. We're part of Ascension Health, which is one of the largest Catholic healthcare organizations in the country. And everybody will tell you if there's no margin, there's no mission. But mission is important. And so there is a recalibration of how we make decisions, how we actually go through an ethical discernment process when we're going to close a pediatric unit. Is that the best thing for our community? It's more than just the cost. It's more than just the profit we could make from it. It's really kind of discerning what is the best thing for our community, for our region, and for the larger healthcare organization. And I've seen our organization make those tough decisions on areas, and my wife, who tells me that having worked in a major corporation, the fact that we start meetings with a maybe an ethical story, maybe a story about problems that have, where a safety issue that's come up and how we're going to improve it. That's really the culture at which we try to promote our healthcare.
Well, it reminded me of Atul Gawande's paper that he wrote in the New Yorker a year and a half ago. I don't know how many of you read that, but he's a surgeon in Boston who writes for the New Yorker, and he wrote about two communities in the Southwest, one in Texas and one in they were both in Texas, yes, El Paso and I forget the other one. Yeah, and he pointed out that the health outcomes were the same in both communities that had similar demographics, whereas the spending was twice as much in the entrepreneurial site as in the community service site, which was El Paso. And so the point needs to be made that not only does it cost more, but those costs are actually harming our nation's health greatly. So this entrepreneurial spirit that's so celebrated in American history has actually caused us a great deal of harm by bankrupting our system and limiting healthcare access because it's beyond people's reach, et cetera. So on the one hand, entrepreneurial spirit can be celebrated in some respect, but it needs to be balanced with the great deal of harm that this has done to our healthcare system as a nation. And we wouldn't stand for that in our school systems. I'll just point that out.
60% of personal bankruptcies are due to a healthcare crisis. So that when you get sick, when you get really sick, you're likely to go bankrupt. And those are even with individuals with health insurance because of the limitation and the caps on policies. So just because you have health insurance doesn't mean that you have an unlimited bank account. And once you've exceeded that, you're in deep trouble. When I worked for United Healthcare, I'd look at claims for a 23-hour hospitalization of $30,000. I'm choking. So they talk about a bed costing $2,000.
But hey, the bed is cheap. It's all the other stuff. $30,000 for less than 23 hours.
Thank you for your presentation. I guess I have more of a comment than a question. There's a large segment of American medicine, perhaps has escaped your attention, that exemplifies many of the things that you've been talking about. And that large segment is military medicine and, in some extent, the VA. I just retired from the Navy. I've been in the Navy forever. One of the reasons why I stayed in the Navy is that we never had to ask our patients how sick they could afford to be. That question never comes up. We will move heaven and earth to take care of a single soul in a bad situation. Lowest died of wounds rate in the history of warfare. The best trauma system in the world extends from Afghanistan to Landstuhl to Bethesda. And so in a context where people come and work and stay for much less money than their civilian counterparts, where there's a rich academic tradition, where there are teaching hospitals all over the place, where people come because they understand, much is in the Catholic system, where there's an ethical imperative to what we do. And I guess I would hold that up as perhaps an exemplar in some sense for what medicine, in your phrase, used to be with Marcus Welby, and potentially could be again, where, again, no one comes to work and sees the next patient because I get extra $50 or $100 in my paycheck at the end of the month. They come because they remember their calling. They remember why they went to medical school at the first place. Now, there are folks who come in and leave because they want to make the big money. But individuals who come and stay because they're passionate about taking care of patients when they're most wounded, most vulnerable, most hurting, most desperate, I think there's a large segment that may be worthy of your attention.
That's a terrific point, and it's so true. Thank you very much. Thank you all very, very much also.